So we're down in Manhattan right now at the Hospital for Special Surgery with Dr. Hoellwarth, who's going to be performing my surgery, which is osseointegration. Would you like to give a brief explanation of exactly what osseointegration is?
Sure. So osseointegration is a surgery in which a metal implant is inserted into a bone for someone who's had an amputation. This is a femur bone. This is a plastic model, but the way that we perform our osseointegration is we take the nail type implant and we prepare the bone and the canal and we insert it. And at the time of the surgery, the implant stays in because of the friction between the implant and the bone. And over time, the implant stays in there because the texture on the titanium surface allows the bone to grow so close to the implant that the bone interdigitates. It locks into the ridges of the implant. And that means that over time, it stays stable in the patient's body. What that allows is essentially a direct skeletal connection for someone's residual limb, their artificial limb to the residual limb. So instead of having a socket where the skin is fluctuating up and down inside of the socket and the socket is twisting on the skin and you are not sensing the ground through the prosthesis, this is rigid, and so the entire energy of the foot that you have connects through your body and it feels like it's stable in place. It does not sag, it doesn't twist. It stays on exactly where you remember it to be, so it's a lot more comfortable and your skin doesn't get injured. And you end up wearing it a lot longer, walking a lot more, and feeling like it's much more part of your body than with a socket.
It's a much better solution than putting your leg in a cup.
That's right.
I can't believe it's taken this long to get to this point, but I guess it's because there's not so many amputees in the world.
Well, the answer is actually even more interesting than that. So when I first learned about osseointegration, I wrote 2 articles. One is just talking about what's happening in this state of the art as of 2020 when I wrote it. Mm-hmm. And then the second one that I wrote was looking at how did we get to where we are today? Because it's not magic and it's not random why today, now, and here is how we're doing osseointegration. And what I mean by that is everything we have is a mix of the technologies that were available, mm-hmm. the needs that were present, and the innovations and the ideas that came to use the technologies that were available. Mm. Why did smartphones come around in 2007? It's because we had the technology of the smartphone technology, the screen technology, the GPS technology, that then someone said, can I put it into a small enough box and market to people? Mm-hmm. So the reason that we use titanium and not other implants is because we don't know why yet, or I'm not aware of why, but we know that, as I mentioned, titanium allows the bone to grow within 50 nanometers of the metal, okay?
Wow.
No other material allows such a tight growth. For context, bacteria is around 500 nanometers or larger. So that's around 10 times the size, right? So the distance from the bone to the titanium is 1/10 the diameter of most bacteria.
That's crazy.
Which means that the bacteria very possibly is physically blocked from getting in with a well-made implant like this.
Wow.
Now, why did we not have titanium to use before that when people were experimenting with stainless steel or other metals? It's because although titanium is the 10th most common element in the Earth's crust, we didn't know how to refine it and get it available. Mm. Again, for context, before World War II, the world had only produced around 2 tons of total titanium. That's it. Now it's considered available everywhere, right. For airplanes, for everything, right?
Right.
So again, the availability of this metal allowed everybody, metallurgists, doctors, people of all sorts, to work with it.
Right.
Now that you can work with it, now you get ideas and understanding. It was in 1965 that the first medical person who was really focused on titanium recognized that not only did titanium feel strong within a bone, this was a rabbit, but that it was so strong that it was much stronger than the other metals, and it got stronger over time. So it was only in the 1960s, 1965, that it was recognized that there is a specific benefit of titanium to use in metal, in bone applications. It was first then used in dental applications because that was the field that medical person, that dentist, was doing. It was in dental work.
Which is where osseointegration started.
Exactly. That's right. So from a effective and medically used scenario, dental implants were the first high volume medical use of titanium. Okay? They proved successful in the mouth, and so it evolved. His son actually then started to experiment with it in the limbs of amputees. But he wasn't the first to experiment with that. Other people in the United States and abroad, I mean, there was the United States Veterans Administration, the VA. There was other places in Ranchos Los Amigos where they experimented with these kinds of things. There was the military looking at these kinds of things. The military hired, contracted a doctor in Texas, Charles Hall, to look at how an osseointegrated implant or a bone-anchored implant could replace a socket. His experiments were innovative, but the technology to make the titanium was not good enough yet to overcome some of the problems of the skin and infection and other things. That's why we are where we are now, is because the last 50 years of working at this, it wasn't random. Someone didn't just wake up and make this.
Right.
There was over 50 years of direct experimenting to see how do we get titanium to work in the body. How do we modify the texture of the surface? How do we affect the bumps? How do we make it strong enough? What diameters are needed? How do we finish the surface? How do we get the skin to work correctly? How do we do the surgery correctly? How do we load them correctly? How do we work shock absorption correctly? Everything comes together from a different variety of perspectives, and that's why 50 years from now we'll probably be even better.
Right, right.
But that's why today, at this moment, this is a reasonable thing to do today, here and now.
So I guess as far as losing my leg, I did pretty good on timing.
You plan it well.
Now, with this whole entire implant is titanium, right?
Everything that you see here is indeed titanium.
Okay.
Yes.
And now, has there ever been any rejection in anyone's bones?
We're not aware of any patient ever rejecting an osseointegrated implant. In fact, titanium is considered, if not then among the most biocompatible metals around. Okay? So no non-biological material, meaning no plastic, no metal, no rubber, has ever achieved
A more cohesive,
a biologic growth. So how do cells in your body stay together? There are things called desmosomes and hemidesmosomes. That's actually biologic bonds from one cell to another cell.
Yep.
That has never been achieved in any non-organic material ever because they don't have the same design. But titanium has allowed the least amount of rejection type of behavior, meaning inflammation.
It's like the least resistant of any.
That's right. It's the most, we call it biocompatible. It's the most biocompatible. It has the least amount of rejection type of behavior.
Incredible.
So unlike stainless steel, unlike bone cement, unlike plastics, where there's a lot larger gap, which allows the bacteria to get in, on the order of 300 microns instead of 50 nanometers. So that's over 4 times the magnitude of difference, right? So, like 10,000 times a greater distance between the implant and the material.
Wow.
So that's why titanium is a very special material.
That's incredible. You seem to be extremely passionate about all of this. It's so cool to see because you have such a vast knowledge about it. I wasn't expecting such an in-depth answer on that. How many people have you worked with now as far as doing this surgery?
Well, my own patients, I've had about 10 of my own patients, but I've taken care of over 100 patients, both surgically and non-surgically, in the context of osseointegration.
And you're working with Dr. Rosbrook.
That's right.
I believe he did my uncle's surgery, or maybe
I did your uncle's surgery.
You did my uncle's surgery.
I did your uncle's surgery.
Oh, sorry.
That's why we're here.
Yeah, that's insane. That's so cool.
Right.
Two Capilettis.
How long ago?
So I started in. Do you want me looking at this camera?
Conversationally,
Okay, good.
Yeah,
The
yeah.
intro was good to the camera.
Good. So I'm the only American who's done a formal fellowship in specifically osseointegration, and I'm the only surgeon who's done 2 fellowships that have focused on osseointegration. So I got my first exposure to osseointegration with Munjid Al-Mudaris out of Sydney, Australia,
Which is where this sort of started, right?
Exactly. So osseointegration as a field for osseointegration for amputees, really started with the other doctors I mentioned. That's the Brannemark family out of Sweden. They used a different implant. It's based out of the teeth. It evolved into the extremities. It's a screw type. And they kind of pioneered this being an effective model for human beings. Okay? In about 1999, the Germans, under Horst Aschoff, began to innovate how to make a non-screw design, a nail type design. Now, they used a cobalt chrome alloy. Okay? Munjid Al-Mudaris happened to go study with them in the mid-2000s, and then when he became his own surgeon, he altered it to be a titanium nail type design. So he's been using fundamentally this type design since about 2013. I went to go study with him in 2019 for 6 months. And so during that time, I helped take care of probably about 100 patients between Sydney and Iraq, where we did some medical missions.
Oh, wow.
And so,
a lot of veterans then.
well, these were actually Iraqi nationals.
Oh, okay.
Yeah, so people who were or were not involved with the military. There are conflicts in addition to the American wars that were occurring. So they have their own issues that were with their own. If you remember that there was ISIS and ISIL, so there were people who were affected by that. There are people who have amputations for non-military reasons, and so we took care of a lot of people with those. And then out of Sydney, Australia, he was able to innovate there earlier because they had their permissions and their freedoms to use the implant earlier. And so he was at high volume sooner than we were able to do that. And so in 2019, I got my exposure through his care. And then in 2021 to 2022, I was a fellow again here at the Hospital for Special Surgery with Dr. Rosbrook. And we also do a large number of these. We're the highest volume of osseointegration in the United States. And so I've got multiple exposures over multiple years, and I continue to be the most published American surgeon in the field of osseointegration.
That's so cool. Very, very cool. Now, so you mentioned that you had to sort of go overseas to get more exposure to this field because, in the US, I feel like everything's so slow moving. Do you feel that the FDA and other organizations actually slow down the progress of where we could be in this field?
The answer, of course, to that question, of course, is yes.
Are they being overly
overly cautious?
Yeah.
I'm going to say yes, because my personal experience with this implant has proven that there is no direct risk of this implant itself, right? Now, we all have to respect why the FDA exists, right? The FDA exists to protect us. There are plenty of episodes in the past in which historically there were medications that were found to be very unsafe.
And they serve their purpose.
And the FDA has the mission to prevent catastrophes from being approved for medical use. Anytime you move slowly, you're going to adopt technology less rapidly than if you move fast.
Right.
You're also going to hopefully prevent major problems by having a slow process. It's impossible to win on both sides of the same coin.
Right.
Now,
Well
the difference
said.
in this specific scenario is that there has been about a decade of demonstrated use of this implant in other countries in over 2,000 individuals. So from my perspective...
2,000 people, and that's worldwide.
Yeah.
Received this specific implant or just
versions of this implant.
So there's only 2,000 people.
Approximately.
Wow.
Yeah. Now of course, every day there's more, and who knows how many this day or that day, but that's a number that I feel safe saying that there's at least 2,000 people who've had an osseointegrated implant in the world.
It's incredible. I feel like honored that I'm going to be able to be part of that.
Yeah.
It's extremely exciting. You ever feel like, hey, I wish I had one of those implants?
I would say, to this point, it's Still better to have a native limb.
To this point.
To this point, it's still better to have
I
a
don't know if
native
you saw,
limb.
Google just came out with that quantum chip.
I know.
If I get one of those on the foot, it'll be quicker than my own brain.
Yeah.
It'll be able to react.
The nice thing about quantum is that there is at least one pair between every quantum individual item. So your foot could be paired with someone else's foot, and therefore you are
could
controlling
work
someone
it?
else. Yes.
Where do you think the future of this technology is going? Do you think in your mind, what do you think needs improvement? Is it what you attach to the end of this, or is it the surgery itself? Where are we putting the R&D into this?
Right. So in my opinion, the first place that research should focus for this is how to truly minimize skin irritation at what I call the skin portal.
So by that, what he means is, if you guys haven't picked up on this yet, this is going to be going into my bone. This portion is going to be sticking out of my skin, and there's going to be a skin portal, orifice, whatever you want to call it.
I like the word portal.
Yeah, it's definitely better than orifice.
You ever watch Teenage Mutant Ninja Turtles?
Oh yeah, I mean, come on.
What do they walk through to get to Dimension X?
Oh, I don't.
It's a portal.
I guess I didn't watch that much.
It's a portal. They
I
walk
thought he was
through a
going to say
portal.
sewer grate.
No, that's how they get home to their sewers. But if you ever watch most science fiction, you open up a portal,
Right.
and then what do you do with a portal? You walk through a portal to a whole new world.
Wow.
That's why I want to call it a portal, because the word portal medically means an opening from one area to another.
And that's a play on words. I'm walking through a portal. Get
That's
that?
right.
Wow.
Because
He's funny too.
it's medically relevant, it's medically, there's justification, and you literally walk through the portal into a whole new world, a whole new life.
That, sir, is what we call a bar right there. That's hilarious.
Where I think research should best be used is in two specific areas. Area number one is addressing, in my opinion, the singular situation that still causes a little bit of hesitancy to get the surgery. Maybe around 5% of patients have irritation at the skin portal, which is where the implant comes through the skin. Mm-hmm. There's a little bit of irritation, of course, because this is just like an earring. The skin itself is soft, and it can move around the implant, and it can get irritated and inflamed. Mm-hmm. Some patients have no problems, and some patients have moderate, and a very few number of patients have recurrent problems with irritation. It tends to be that the patients who are thinner with a tighter skin envelope, even patients who have burned skin, do the best because the skin is very stable. Okay? We aren't 100% sure how to totally minimize that. Again, we're working toward it, but that's where I think the most valuable kind of fundamental research can be done. We know how to get the bone to grow in. We know how to get it stable. We know how to take care of situations in which the bone may break if you fall and have a fracture. We know these kinds of things. In my opinion, that's the main clinical issue to now resolve. Okay? And then the second thing where I think a lot of innovation, or maybe not innovation, but research and understanding, is accessibility for patients. Again, this is not yet a commercially available implant. It does great, its track record is awesome, but because it's not widely available, the number of patients who are aware of it, the number of doctors who are aware of it, and the availability to patients remains low. It's a slow process to get it, and it is a effortful process to get it approved for each patient.
Right.
Once it makes through once it's commercially available, then that process becomes much easier. And hopefully, then two critical things happen. One, because many more patients have access to it, we now understand how to do it safely for many more patients, and how to maximize the recovery for patients who have to have an amputation.
Right.
And then super interesting is in its most basic concept, this is just a titanium stick. The surgery behind it is very approachable, reasonable, and a lot of surgeons can do it. Meaning a lot of patients around the world can have this done.
Right.
It doesn't have to be exclusive to people with tremendous resources. It can be something that can be available to people with relatively low resources who have an amputation.
Got you. So you're saying the demand will go up. Obviously, practice will skyrocket once that happens, and it's not a crazy thing to come by.
Right.
And it's not an insane.
And
you know, it sounds crazy to do
who
it.
have low resource can have access to this tremendously helpful care.
And as far as complicated surgeries go, I mean, I've done construction, right? I've hollowed something out to put a nail in it.
Right.
This is essentially what that is.
Yes.
This is way less complicated than a knee or hip replacement, correct?
Yes.
So like, I mean, I guess I could see it skyrocketing in growth,
right?
If what you said comes to be.
That's right.
That's very cool. Now, in my case, right, and not just my example, I guess it goes for anyone's example. When you first get this surgery done, you hollow out the bone. Mm-hmm. Is that when you must be at your most vulnerable at that point, the bone itself, right? Does that weaken it to a point where you actually, let's say I got the implant and I tried walking on it that day.
So so you're talking about how may a bone be injured? Certainly, the time when a bone actually sustains the most amount of injury is the extended period of non-weight bearing. So
really,
bones, our skeleton has two functions effectively. Mm-hmm. One, it's a calcium supply for our body. Two, it is the rigid scaffolding that our tendons work on to make us move.
Our framing.
Our framing. Our skeleton is a tremendous metabolic demand on our body if it's not used. If it is otherwise a useless thing. If we lie in bed, our skeleton is useless.
It's going to eat us alive, you're saying.
It takes a lot of energy to keep a skeleton healthy. That is, if we're not walking on it, it's useless. Its only purpose is to provide a structure on which we locomote.
Very interesting.
So if you're not walking on it, you're spending a lot of energy to maintain a skeleton with no value derived from that metabolic investment.
Right.
So our bodies get rid of what we don't use. So when you don't walk on the bone, our bodies actually resorb that skeleton over time. The bone becomes thinner and weaker and more fragile.
Interesting.
So your tibia...
And that works inversely, doesn't it?
Yes, that's exactly the point. Okay. That's exactly the point. So your right leg probably has tremendously more bone density than your left leg.
Right.
Because when you stand, you likely put more weight on this. When you're walking, you put more. And when you are making small trips and you don't want to put this leg on, you're hopping on this leg.
Right.
Now, this leg is probably less dense than it would have been had you not had the amputation.
Right,
because you're less active now than you would have been had you not had the amputation. Mm-hmm. But when we put this implant back in, now we're directly loading the skeleton again. Directly loading the skeleton again. So this part of your bone will have direct skeletal loading. So this part of your skeleton will rapidly increase the density because resources will be recommitted to supporting that bone.
And so you're better off getting this surgery sooner than later.
That's right.
Amputated because your bone will have more strength.
That's right. You will have fallen a far less distance from your best before you started loading it again. Mm. So young, healthy male astronauts have had hip fractures before after returning to Earth.
Wow. Because
their bone density has decreased in the months that were in space with no weight on the bones.
Wow.
So they've fallen and broken their hip the way that an old, weak person would have.
Is there a way to measure bone density?
There is. You can get either, the classic way is to do what's called a DEXA, where they measure, it's a special type of x-ray, and they measure the density at the neck of the femur and a couple other places in your body. Mm-hmm. But when you get a CT scan, some types of CT scans can be calibrated such that it can then measure the bone density.
Incredible.
There's other ways to do it too, but those are the most common right now.
Right. Learning a lot here today. Incredible. And now, as far as your expertise goes and your practice, you don't deal with anything past this point, essentially, the prosthetic itself.
That's right. So I am a surgeon and there are prosthetists.
Right.
A prosthetist is the person who deals with the prosthesis.
Right.
Now I am legally the person who writes for the order to place the prosthesis and generally the type of prosthesis, but the prosthetist is the person who has formal training in managing and placing and adjusting a prosthesis.
Gotcha.
Just like a physical therapist is the person, I write the order, but the physical therapist is the person who executes and is a specialist in the exercises and how to do it with the patient.
And so now talking about getting to that point, let's say we had this surgery today. About how long am I looking at recovery time?
Right. So let's put a scenario of January 1st, because that's very easy for people to keep in mind, right?
2 days from now.
Right.
That's yours if you want.
Yeah. So if we were to have an osseointegration surgery on January 1st with the implant that our practice uses, this nail type implant, we generally do a single stage surgery, meaning the implant is put in and the skin is closed and we'd have no further expected surgery on January 1st, for example. Depending on how firm the patient's bone feels at the time of surgery, we would then tell the patient to be non-weight bearing for 4 to 6 weeks. What that does is it gives the skin time to heal, the swelling to reduce, it gets the bone an opportunity to grow in. So most fracture care is spaced on the order of 6 weeks because that's a critical time point in how much time it takes for osteocytes to start laying down bone. So that means that in those 4 to 6 weeks, the bone can begin to deposit itself into these crevices, giving some new bone to help resist pullout and twist. It's far from done maturing, but it's gotten a pretty good way in the process, okay? So after that 4 to 6 weeks, our routine currently is that you come back to the office, we make sure all is good, we take an x-ray, nothing's moved, and we make sure you're not having pain. Then you start loading with a temporary loading prosthesis. That is a small rubber footy, and at that point, you start putting progressive load through it. That harkens back to what I said about the bone responding to force. So if the first time your bone feels force, it's your whole body weight, it may exceed the ability of your bone to manage it. Just like you trying to learn a new skill or lift a new weight.
Right.
You can't do everything the first day.
Right.
So you give the bone a low achievable amount. We found that 25 pounds has led to no problems in terms of the loading. So we
Gotcha.
start our patients at 25 pounds. And we tell them you can put 25 pounds on this at a time, and we recommend about 10 to 15 minutes per session for a total of about an hour a day during this loading phase of another 4 to 6 weeks.
Is that a painful process?
The process is intentionally not painful.
Okay.
So if you feel pain,
That
you
means
should
you're
slow
doing
down.
too much.
You're doing too much.
Okay.
Your bone is not ready for it. Okay.
Gotcha.
So you slow down. We haven't had situations in which patients have had to slow down. So far, we think that's a really good process, which means if you get your surgery on January 1st and you are on the 4-week timeline, then on approximately February 1st, you'll start to load the prosthesis. Then that's about 4 more weeks. And then about March 1st, you'll get the leg attached to your prosthesis. So if you're on the 4-week timeline, you're approximately 2 months from the day of surgery, you start walking on the osseointegrated leg. If you're a little bit slower on a 6-week, then approximately 3 months. So that would be April 1st. There can be times that you may want to delay if a patient is not as stable. They have more difficulty walking. If a patient has travel issues and they can't get back for that. There are many times that some different scenario may arise, and this is very flexible. There's not a rigid timeline that must happen. It's the freedom to progress.
Right.
So someone in your scenario, you're young, you're healthy, you're well coordinated, you only have one limb lost, and your amputation is through the tibia, meaning you had your knee. I wouldn't be surprised if within the very first hour after getting this leg reattached, you feel comfortable walking without crutches.
Wow.
That changes for people who have less good balance, people who may have poor balance for a variety of reasons. That changes for people who are older and not as strong. That changes a lot for people who have an amputation above the knee. We call it transfemoral amputation. And certainly for people who have a bilateral amputation. Because if you imagine wearing ice skates or a high-heeled shoe, you're now at a different level. You're not walking on your normal foot, so your balance is off. But with one good foot, you can feel very balanced on that side, and the other side will feel so much better and more natural for you than your socket that you will go from a place of relative imbalance now to feeling so much more comfortable and native that you will actually feel better quite rapidly after getting this osseointegration because it's directly linked to your skeleton.
And so you're saying I would feel as if I could walk, but if I attempted to, what are the major risks if I tried walking out of here the day you did the surgery?
I would say there are no risks to actually walking out of here. The only scenario in which, so if you don't fall, if you don't have a trauma, I'm not concerned about anything. The risk
Not
is simply
spinning or
no,
turning or coming out.
not at that point.
Wow. Do you want me to be the first guy who walks out of here after you do the surgery? Because I'll do it.
You won't be. It's already,
What? So you gave someone a surgery and he walked out on the limb?
2 months later.
Oh, 2 months, 2 months.
Yeah.
I got to beat that. I'll beat it.
No.
Have you ever heard of compound BP 157?
Oh.
Okay, so it's this peptide that allows people to heal at like insane rates.
But I'm not going to let you do it.
Okay.
I mean, you can do the
was gonna-
peptide.
I
I'm not
was-
letting you walk on it.
Oh,
You can
yeah,
do the peptide.
no. Well, before 2 months?
I've had, so in Australia, you know, Moonjet has done that. He's had people like walk out the next day. Here's the thing.
High risk.
Yes.
Very high.
It's everything in life is a risk and reward.
Right.
Okay. If you walk out of here on the day after surgery and you never have a problem, we'll be high-fiving ourselves forever.
Right.
If you walk out of here on day one and something hurts and it
Forever
falls
like
out,
this.
yes. So
Yeah.
you know,
The dichotomy of
if you wait if you wait a simple 2 months, I know it's like, but you wait 2 months.
2 months is it would
and
be
then
incredible.
you have,
I
and then
already
you have
have it in my
you have
mind. It's gonna be
99.99% confidence.
Yeah.
That's the way to go.
Yeah. That's the way I would go. I always err on the side of caution, honestly.
If it were like 12 months, well, then it's a different thing, but it's 2 months.
With that being said, during my recouping phase, is there any type of supplements that you do recommend, or anything that you
We generally recommend, sort of semi-conventional things: calcium, vitamin D. Mm-hmm. I recommend all my patients go on not an inappropriately high, but a high quality, high protein diet. Mm-hmm. And I like creatine for my patients. All those things have been proven
so
safe
popular.
and effective.
Yeah.
Yeah.
Creatine. All right. Well, I got creatine.
Creatine's great.
Start taking some of that.
Should do 5 milligrams a day.
You do?
5 grams or whatever, five units.
It's become extremely popular. Apparently, it's very good for your cognition and.
What it's really
benefits.
clearly really good for is helping your muscles recover from exercise. That's the fundamental reason that it's used. Okay, it is proven safe in every population that's been studied: young, healthy athletes, people with strokes, people with physical injuries that are going through physical therapy, patient with cognitive issues. And I don't know if we know that it directly helps with mental acuity, but we believe perhaps the way that it does help is you're physically more active. So if you're older and you're having trouble with mobility, you tend not to do as much, and as a consequence of not doing as much physically, your brain also reduces its function. If you have more ability to do things physically, your body is moving, your brain has to make decisions, you're getting out of the house, you're doing things, and therefore as a secondary benefit, your brain remains more active because you're physically active.
It's like a catch-22
Yes.
type of situation.
The spiral can go down, the spiral can go up.
Right.
So I recommend that everybody does a routine normal dose of creatine.
I like that.
The number of the downsides are basically unrecognized at a normal dose of creatine.
Okay. Well, I'm definitely going to be taking more creatine. Do you sell creatine?
I don't sell supplements.
You do now. You just did a 5-minute commercial.
I'm recommending a generic supplementation.
Gotcha.
But I'm not pushing a specific product.
No. All right. One other quick question I have for you, and this one's kind of cool. It just made me think of it. Your bones have a certain level of strength, and everyone's heard this rumor or whatever you want to call it. You break your leg, and when it heals, it's actually stronger than it was before. Is that true?
No.
Really? Interesting. So it's like a myth.
So the answer to that question is a very complex yes, maybe, but probably not, in the sense of your bones have developed their shape based on our genetic programming. Don't sit on that. It's not weight bearing. You want to send it to it's fine or somewhere else. It's actually it's like plastered to the wall.
It's a wall unit. Yeah.
Yeah.
You could tell
you want a
someone's done
stool?
that before.
Okay. So the answer to whether our bones are stronger after being broken and healing is a very complex, usually not, maybe in some cases, yes. But here's where it comes down to, okay? Our bones have the shape that they do because, of course, we are human and our genetic code tells it to do this rather than the shape of a horse or a whale. But then also they shape slightly based on our weight bearing and the other forces they have. That's why at this region where it's narrower, the edges are thicker, the cortex is thicker, but where there's a greater amount of area of the bone, the edges, the cortex are relatively thinner.
Larger area to hold the weight.
Right. So now if you have an injury, bone is laid down because, actually this is a very interesting point. The reason that osseointegration works and bone lengthening works and fracture healing works and our skeleton gets back is because the skeleton bone is the only solid organ that heals with its native function. It's the only solid organ that heals with its native function. So if you cut your skin, you see a scar, right? Obvious. Why?
Okay.
Because on your skin, it's not just the scar material, it's hair cells, it's other things that sense, it's stretchiness, all that kind of stuff, right? So whereas you see that visibly on your skin, if you have a heart attack and your heart muscle has injury, that muscle is now a scar. It doesn't move the same way.
Right.
If you have a lung infection or a lung and you get shot in the lung, it's a scar. It doesn't absorb oxygen, it doesn't pass blood. Your liver, your kidney, when there's injury, there's a blood flow problem, it dies. It heals not as that native tissue.
Right.
When bone is fractured, bone is essentially collagen. Collagen is the compound that is a scar compound. So when your skin gets injured, it's collagen. When your heart has an injury, the collagen is the scar.
Gotcha.
When your kidney gets an injury, it's collagen that's the scar. So when your bone fractures and the response is to form a scar, it's collagen.
Right.
And that's why
It's
your
the
bone
only
can be
truly
modeled.
regenerative part of your body.
It can make its own native tissue in the healing process.
Thank you
when
for
that
breaking
happens,
that down because I had no idea what that meant.
right. So when your
very
bone
cool.
forms
Very
a
cool.
scar or a callus or this bone around it, you can argue that maybe it's stronger if it laid down a large area of bone. So the answer is maybe in some scenarios, yes.
Right.
But
Case by case.
But you will not make yourself a stronger person by breaking your body over and over again.
Right. Interesting. That's very interesting. I wasn't expecting that answer.
So Anthony, here is you standing for an X-ray. And this is a alignment X-ray of your right side, which is your full limb, and your left side, which has the amputation through the tibia. You're wearing your prosthesis in this X-ray, okay? So actually, your prosthesis is rather good. Your hips are approximately level, your knees are approximately level. So you have a well-made prosthesis and a prosthetist who's doing a good job to keep you aligned. That's
Shout
great.
out POA. They always took care of me.
There you go. In your scenario, you struggle partly because you just have such a short residual limb. This tibia is very short. You know, if we measure it on a calibrated X-ray over here, you have maybe 6.5 centimeters of total tibia, which does not give a long lever arm to hold a socket. And because you're trying to hold a socket on a short distance, there's not a lot of grip, so it can slip off. In your case, they put a sleeve that comes up above to increase the grip, but that goes over your knee, which reduces motion in the knee and gets hot and gets uncomfortable. Which means we can try to put an implant inside of your bone, but it has to fit within what's called the physeal scar, the top of the canal for your bone. So you're going to be one of the shorter limb segments that we've worked with. Okay? So in order to do your care, we had to template your leg. So we did a CT scan here, and this is your leg with your socket on. So this is the pin that you have from your socket. And so here we have a 3D model of your bone.
And you can see that pin is not going straight as where my leg would go.
That's right.
Which is what really throws my balance off so much.
Exactly. So the line that we have here would be coming approximately here.
It's pretty close, but
It's pretty
off.
close. But don't forget, that's how you wore it at that moment. Every time that you put that leg on, it changes position.
I am moving. If my leg was still connected, watch, it would be like this.
Right.
That's what I'm doing.
Yeah.
But it's just staying still.
Exactly.
That's
because
how off it is.
It's you're wearing pants that are too big. You're wearing a shoe that's too big. That's the whole concept. And there's no way around that with a socket. And not only that, but really, this is why it's undervalued of what a bone-anchored prosthetic limb, that's why it's undervalued what a titanium transcutaneous osseointegration nail, a Titan, what that can do. Because once that Titan, that osseointegrated nail is placed, it doesn't change in your bone. Its position is stable. So right now, when you roll this prosthesis sleeve on for a time, it might put the pin here. It might put the pin here. It might put the pin here. And that comes down to how consistent you are, how consistent the shape of your leg is, how consistent the wear in this thing, how much it stretches. Every day, every moment is a new thing. And so it's very frustrating. When you put the osseointegrated prosthesis on, it's the same place. You know exactly how long, how fast, how stiff, exactly what rotation. It doesn't change.
Consistency.
So when we use this 3D model, we size the implant exactly for you. This is obviously not yours. This is just another example. But effectively what's going to happen here is when I do this surgery, I'm going to put that implant into your bone basically like that. And we're going to let it just start to have bone growth for about 4 weeks, let your swelling go down from your surgery, and then you're going to start loading it. So you're going to start giving the bone some force to feel as you push that implant. Now it's obviously not going to move as much as we see on the camera here, but that's the concept. There's going to be force going through the bone. The bone will say, there's work for me to do. I'm going to devote nutritional metabolic support to lay down new bone, to give those osteocytes nutritional reinforcement to make more. And over the months and the years, we'll find that the bone that you had surrounding here will go from this relatively narrow cortex. You see, it's a relatively, like the amount of dark bone on the edge is very small because you haven't loaded it for a long time. If we took another CT scan a year after your implant, it would be thicker and it would be denser.
Make itself stronger again. Now, once I am, you said it continues to strengthen over time. Is there a certain point where that plateaus, or is it always going to be strengthening?
So the answer, will it ever plateau? In truth, there must be, because our skeleton peaks at its density somewhere in our 20s to 30s. Okay, that's why old people get osteoporosis, they get low bone density, whereas young people very infrequently will have that. It's an older person's disease. Just like every other part of our body, we increase our physiologic capacity and peak in our 20s to 30s for most things, and then it decreases from there. So the answer of, is there a peak? Yes, because you will never be as strong skeletally as you will be in your 20s to 30s. So eventually it won't be stronger than that. The other part of that answer is also the skeleton that is reinforced likely will not exceed the native side, okay? Usually bone density, it's very difficult to increase the actual density of the bone. It's much more reasonable to stop the decrease. The decrease. So your left side and right side may normalize. They may become more similar, but it's unlikely that the left side would exceed the right side.
Understood.
But at the same time, just like any maintenance, whether it's a language acquisition, whether it's exercise, whatever it is, the key thing is maintaining through use, regular use. So your ability to maintain the use of that leg will be the most important thing to maintaining the strength in your left side, the balance in your body, minimize the pain in your back, and preserve you physically.
Which brings me directly to my next question.
Perfect.
I shouldn't have any limitations in the gym other than mobility, as far as, I used to have extremely strong legs.
Right.
When I was younger, I could bench I I could squat like 400 pounds, something stupid like that.
Right.
Should I mean, obviously, other than how a normal person would work their way up to that weight, once I have this in my leg, should I not be lifting heavy weights, or should I be living as I was?
So I'll say it in two different perspectives.
Okay.
Perspective number one is that I don't recommend that almost anybody does particularly heavy squats. Now, squats are very helpful from a mobility perspective and from a motion perspective, and I think most people should try to do squats at body weight and maybe up to about a 1.5 times body weight or about there. Why do I say that? I say that because the force that goes through your kneecap when you do a deep knee bend is at least 5 times of the force that you put vertically.
Wow.
So that magnitude of force going through your knee is tremendously high.
Yeah.
So
it's like a death sentence for your knee over time.
that's right. So what is the value of total maxing out on a squat?
Right.
I'm concerned that it's more for your ego than it is for your health.
Exactly.
But that's not to say that you shouldn't do exercise and full mobility work.
Yes.
Okay?
Yeah.
Then the second part I have to say is, whereas our bones have the ability to respond to force over time, this implant is not alive. This implant is a metal object that at some point it will break.
Right.
Everything at some point will break. Your bones will eventually break, but if you go slowly, they won't. This, we have to fit the size of your bone inside. So the diameter of this is limited by your bone. The diameter is the most important factor in terms of the strength of the implant, okay? Yeah. So again, like all things in life, you get a fancy car, yeah, you probably could drive at 250 miles an hour.
Not a good idea.
That's not the goal of getting your fancy car.
Right.
The goal of the fancy car is to have a nice, comfortable ride, to be happy with your investment, and to make it home every time, and also not to pay insane amount of maintenance from ruining it.
Right.
So I recommend treating this like a nice, fancy car. I want you to go out, I want you to do a lot of mobility. I want you to have the freedom to go wherever you want. I want you to push it responsibly. I don't want you to drive it as hard as you possibly can imagine. Right? But I want you to have full mobility. So I want you to do all the body weight exercises you want to do. I want you to climb. I want you to feel happy to do that. Recognizing that if you do something that exceeds it, you may be here to, to visit me again.
That's a great answer.
Yeah.
Thank you.
I mean,
how
we have people
strong
go
is
swimming.
titanium in comparison to other metals? Stainless steel is very, very rugged, isn't it?
So numbers are hard to understand. So let's go through a relative density to young, healthy bone. So we'll call you an average young, healthy man. The cortex of your bone is, we'll call it 1. Okay, that's 1. Whatever unit it is, that's 1. Titanium is generally on the order of 4 to 10 times that stiffness.
Oh, wow.
Okay. So we consider it, from a biomaterials world, relatively similar to bone.
Okay.
Things like cobalt, chrome, or steel are more times stiffer.
Do you have one that you could use with a number to represent that? Like would stainless steel be like an 11 or something like that?
Compared to your bone, titanium is on the order of 4 to maybe 10 times the stiffness. And this is going to vary based on everybody's bone and the exact way they make the titanium and many factors like that.
A lot of nuance.
Right. But in general, stainless steel is going to be about twice the stiffness of that. So it's even further away from the stiffness of your bone. Which is why another reason titanium is good is because when your bone starts to feel load, the titanium is more likely to deflect more similar to it than stainless steel. But again, the most critical thing about the titanium is that the distance between the bone and the titanium in a well-made piece of titanium is so small compared to everything else. So the amount of movement, the amount of flexion that occurs between these gaps is so much less with titanium than with stainless steel or any other implant.
Right. I'm super excited to finally go through with this. I've always dealt with this and I made the best of it, and it's been pretty good, but it's kind of rough. It kind of sucks.
Yeah.
Waking up every morning and the first thing I have to do is put my leg on. It's not like it's a hard thing to do, but every single day it takes a little bit out of you. And now that the prospect of being able to wake up every morning and just my leg is there just like everyone else's is such an exciting prospect. And the fact that I'm going to be able to be so much more mobile and active. You know how bad I just want to go on a walk and not have to worry about it? And like, you know, I got my daughter at home, she's 18 months old. All she wants to do is go on walks. So I just cannot wait to get this done and be mobile again and active. I'm looking forward to it more than you can probably imagine. So I just thank you. Thank you so much, man.
Of course.
I can't wait to go down this road with you. I was telling him this morning, I just want to get it done. I wish I could do it today.
Me too.
Squeeze me in.
2 weeks or so, right?